Namaste, my dear brothers and sisters. The love and blessings of the Mother and Sri Aurobindo to all of you from Sri Aurobindo Ashram Delhi branch. This devotional song in the melodious voice of Prem Shila expresses the devotees' respects for Sri Aurobindo. And through all the modes that we use in the sadhana, the three major modes which we come across in the Gita, it starts with Sabhakti Pranam, my respects to you because of my devotion to you. Sagyan Pranam, my respects to you because of the knowledge that I've gained from you. And finally, Nishkam Pranam, that is my respects to you, not desiring anything as a fruit of my action. And these, in fact, are the three major instruments that we have: the head, heart, and the hands. And using all these in the service of the divine is what yoga is about. Using the head to know the best, using the heart to love the best, and using the hands to work for the best, the highest, the one that is everything, that is the divine. Today's topic, the kidneys. We have seen that all parts of the body are ultimately geared towards providing all cells of the body the type of conditions under which they can continue to live and function satisfactorily. And these conditions include the availability of oxygen and food, and the right temperature, the right acidity and alkalinity, the right saltiness in their surroundings, in the fluid surrounding them, and not letting the waste products such as carbon dioxide and ammonia accumulate. The kidneys play an important role in eliminating the waste products which result from ammonia. I mean, rather result from the metabolism of proteins and nucleic acids. And the principal product that everybody is familiar with that the kidneys eliminate is urea, which is manufactured from ammonia in the liver. And that is again important because ammonia is an extremely toxic substance, and therefore, even before it gets eliminated, it's important that it be converted into a relatively harmless substance like urea. The kidneys are that way playing an important role in providing the cells an environment in which waste, or at least one waste product, ammonia, does not accumulate. While this is common knowledge that kidneys help us eliminate waste products, what is not so well known to the general public is that kidneys contribute in other important ways to providing the cells the right environment. The right amount of fluid and saltiness, that is, maintaining the amount of water in the body constant and the saltiness of this water constant. Saltiness, particularly with respect to the two major types of salts we have, sodium and potassium. The levels of both these are regulated by the kidneys, and the kidneys play an important role also in providing the right degree of acidity, or rather alkalinity, because the extracellular fluids are slightly alkaline, providing the right degree of alkalinity to the cells in their surroundings. So they are important not only for elimination of waste, but also for maintenance of water and salt balance, and for water and salt balance, and for regulating the acidity and alkalinity, what we technically call the pH of the blood. We'll be concentrating primarily on the elimination of waste products today, but it's good to keep in mind that the kidneys are major regulators of the others too, and that in fact is one of the things to be taken care of when a person's kidneys are failing. That becomes a major source of concern and has serious consequences: the disturbances of the fluid and electrolyte balance, and the acidity and alkalinity of the fluids of the body. With that introduction, now I can go to the slides. This course and other activities of the YES program are a part of the 150th birth anniversary of Sri Aurobindo, and the 75th anniversary of India's independence. The realistic anatomical pictures in this presentation, as in the others, have mostly been taken from Tortora and Grabowski's Principles of Anatomy and Physiology. Now, this is a picture of the kidneys and associated structures. And as you can see, the kidneys are bean shaped. On the other hand, a popular variety of beans are called kidney beans. Uh, Depends upon whether you are more familiar with the kidneys or the beans. You can consider either of them more appropriate. Uh, like all organs, the kidneys are supplied with blood, and this is the major artery from which these branches arise to supply the kidneys. And the blood returning from the kidneys to the heart comes through these veins on either side and then goes towards the heart. From each kidney, you can see arising a thin tube, the ureter, which conducts the urine from the kidneys to the urinary bladder. It's the bladder and the urethra, the tube through which the urine finally is eliminated, the tube through which we pass the urine out. And this is the inside of the excretory system of a woman. Because behind this uterus, sorry, behind the urinary bladder, you can see uh, the uterus, which is the structure in which the baby grows. And behind that, you see the rectum. So, corresponding to this, a woman has three openings, one behind the other, very close to each other, the urethra, the vagina, and in the anus. And it is because of this that urinary tract infections are more common in women because the urine, is very clean. You might have seen very often when your urine is sent for culture, the report comes back urine sterile after 48 hours of incubation, which means for 48 hours the urine was provided, urine was kept in a medium which provided the ideal sort of nutrients for a large variety of germs. And yet, since there were no germs in the urine, no germ grew in the urine, and urine continued to be sterile even after those nutrients for the growth of bacteria were provided for 48 hours. So urine is a very sterile fluid. And that's why some people can also drink urine. And in fact, urine therapy or drinking urine for staying healthy is a fad with many people. Whether it's a fad, whether it's helpful or not, we'll not get into that. But urine is sterile. But compared to that, the vagina and the anus, they are dirty. Dirty in the sense that they have a large bacterial population, some of which can be harmful, and some of which can, if they get into the urinary tract, can give urinary tract infection. And that's why it's more common in women, urinary tract infection. And one of the precautions to be taken is while washing this area, go from the front back, not the other way around. Because better to go from the clean towards the dirty area. Don't bring the hand back from the dirty area towards the front. This is a sort of schematic diagram, simpler to understand and visualize the type of picture a physiologist rather than anatomist might show. Uh, so uh, on this side is the kidney as we see it outside, and this side it has been cut open. And you can see that uh, there seems to be something that flows through these structures towards the ureter. So the urine that is formed is collected by these structures and the calyces, and then eventually they come to the calyx, and to the pelvis. This is called the pelvis of the kidney, and from there it flows into the ureter, and from the ureter to the urinary bladder. Sitting on top of the kidneys are the adrenal glands, again cut open on one side, and these are the source of adrenaline and also of the cortical steroids, cortisone and aldosterone and such substances. So this is the adrenal gland. While it's called adrenal because it is close to the kidneys. Kidneys are also referred to as renal, and so these are adrenal. They're close to the kidneys, but functionally, it's not that this proximity uh, makes the functioning of the kidneys or of the adrenal glands any easier. They still function the way they would, irrespective of where the adrenal glands and the kidneys were located in the body. Now, if you look at this part of the kidney and this part, this is full of the units of the kidney where the function, where the formation of urine takes place. These structures are called nephrons. So, nephron is the unit, structural and functional unit of the kidney. And this is somewhat how it looks. It has a cup shaped structure from where arises a tube. And this tube is twisted in all sorts of ways. Those twists have been minimized for simplicity. And this is, since this is at the beginning, that is near to the beginning of the nephron. This is considered the beginning of the nephron. It's called proximal. Proximal means near. Hmm. And convoluted because it is twisted tubule. And then this continues into a long, thin tube, uh, which is the descending limb, and then forms a U shape, takes a U shaped curve, and then continues as the ascending limb. Both these have thick and thin segments, the descending and the ascending limbs. And then, comes the distal convoluted tubule, again, twisted structure, but far away from the beginning of the nephron, and therefore distal. Distal means far away, at a distance, convoluted tubule. And the distal convoluted tubules from different nephrons feed into a collecting duct, and a large number of collecting ducts would then feed into a calyx, and a number of calyces will then feed into the pelvis of the kidney. So there's a sort of a convergence of these structures to collect the products coming from all the nephrons. Now, how many such nephrons are there in the body? About 1 million in each kidney. So the total number is about 2 million nephrons. And what is the length of each nephron? All these tubular structures, if they were straightened out, it is about 5 centimeters. So an extremely thin tube, diameter only 10 to 60 microns. What is a micron? A micron is 1,000th of a millimeter. Millimeter, as you know, if you look at the measuring scale, uh, the side on which you have centimeters, you have small, small divisions, 10 divisions for each centimeter. Each of those is a millimeter, 1,000th of that. You can imagine how thin it is. So these tubes are that thin. Different parts, the diameter varies from 10 to 60 microns, but in any case, extremely thin. And such a thin structure has a length of 5 centimeters. Now, and there are 2 million of such nephrons. If you were to stretch out all these end to end, it will give us a distance of about 100 kilometers, approximately the distance between Delhi and Mathura. So that is the type of length that we have, uh, total length available. And why? And within that, again, there's a provision for multiplying the surface area the way we have in the kidneys. Why all this is important, we shall see as we go along. So we have 2 million nephrons, and there is plenty of reserve. And a person may lose one kidney, and persons donate a kidney sometimes for because the person can live on one kidney. They donate it to a patient who has chronic renal failure, and for that, the ideal treatment is to do a kidney transplant of a matching kidney. So a kidney which is otherwise matching, that can be used for transplantation, and that is possible because there is a plenty of reserve. This reserve is useful also when there's a damage to the kidney because of disease. So a person may have 50% of the renal function lost and still continue to function normally. The renal function tests may still be normal. Uh, if the damage involves death of the nephrons, uh, the nephrons do not regenerate, which means they don't get replaced by new nephrons, but they can undergo a hypertrophy, which means they can undergo an increase in the size, so that now the nephron can work more. It can say do as much job as 1.5 normal nephron because of this increase in the size. That can happen. So that sort of a reserve is also there. So apart from the reserve that we have of at least one kidney, if the nephrons start dying, we also have the reserve of these neurons increasing in size, hypertrophying, so that each neuron doing more, starts functioning as uh, say 1.5 or 2 nephrons, so it can work harder than a normal nephron. Now we'll concentrate on this part, the beginning. Now here, this cup-shaped structure has in it a bunch of blood vessels, and it is here that the filtration takes place. These capillaries, this bunch of capillaries naturally originates in the artery which is supplying the kidney, and the next picture shows you the details. Here is blood entering, and through a rather pretty big artery here, an arteriole. It's not very thin. And then it breaks into this bunch of capillaries and then comes out through another arteriole. Now, this arteriole, which is coming out of the uh, this cup-shaped structure, is slightly smaller in diameter than the one through which the blood enters this bunch of capillaries. So you can imagine that if this is a little smaller in diameter, these capillaries will have a pretty high pressure. In fact, the pressure in the glomerular capillaries is much higher than the pressure in the capillaries in the rest of the body. And you can understand why so, because here filtration has to take place. Fluid has to get filtered across this capillary so that eventually this from this filtrate, that is the fluid which comes out as a result of filtration, from that urine has to be formed. And filtration will be easier if the fluid flows in at a higher pressure. And pressure considerably higher than in the structure, surrounding structure. So that is ensured by the blood flowing in, not through very small arteries, but through arterioles, which are pretty big, in which the pressure is still considerably high, and then coming out through a blood vessel, which has a diameter smaller than the one through which the blood enters here. Okay. So this is the bunch of capillaries called the glomerulus. Now let's have a look at the filtration surface. That is, what is it that is between this capillary and the area in which this filtration eventually takes place. Now, if you look at the lining of the capillaries in the glomerulus, you find that they have a special type of a lining which has these punched out holes 40 to 100 nanometers in diameter. Now, how big is a nanometer? A nanometer is 1,000th of a micron. You know, so a micron is 1,000th of a millimeter. This is further 1,000th of that. So you can imagine very small holes, but then big enough for water and other small molecules to pass through. But then this is not all. Outside there is a lining, the basement membrane, which has a sort of architecture, which again leaves spaces for fluid to pass, and the diameter here is about 10 nanometers, smaller than this. And then we have surrounding this the cells, which have these finger-like projections which interdigitate, which fit into each other. So these are the cells, which have sort of feet. That's why they are called podocytes. Podo, refers to feet. And these are the feet, or you can say fingers, or whatever you like to call them. And they interdigitate, and that gives us these gaps have leave spaces of about 20 nanometers. Now these three, so it's a triple sieve, uh, 40 to 100 nanometers, 10 nanometers, 20 nanometers. Now this gives us a sieve which has an effective pore size of only 6 nanometers. Why? Smaller than any of these. That happens because these different openings are not aligned with each other. They are not in register. And therefore, because they are not aligned, the effective pore size is only 6 nanometers. And that is how only very small molecules can pass through and form the filtrate. Now, this shows the same thing uh, in a simpler way, more easy to grasp. So, this is the capillary in the glomerulus lined by a single celled lining. The lining has just one layer of cells, and it leaves, it has holes, punched out holes in this, which have a diameter of about 100 nanometers. Then you have a membrane between this and the glomerular lining, And then the glomerular lining here has these podocytes. So here is a further simplification. The glomerular capillary, leaving these gaps over 100 nanometers, the basement membrane, leaving these gaps about 10 nanometer diameter, and then these podocyte or the foot processes, these finger-like projections, leaving behind gaps of about 20 nanometer diameter, and you can see that they are not in register, they're not aligned. So if fluid has to, to curve around like this to be able to get out. So the effective pore size is only 6 nanometers. As a result of this filtration, how much is the filtrate formed every day? 120 milliliters per minute. So you can see how much per day. 120 multiplied by 60, that is in 1 hour, multiplied by 24, that is in 24 hours. So in one day, the amount of filtrate formed is about 173 liters. And this would be enough to fill uh, about 10 buckets, medium-sized buckets. Hmm? So you can imagine that if all this were to be lost from the body, we'll be running to the toilet uh, all the time throughout the day and then drinking enough water to be able to replace it. So obviously that doesn't happen, which means there is a mechanism for now reducing the volume of this filtrate. But then what is it that is filtered? Water and the glucose dissolved in it and other small molecules like amino acids, which are the building blocks of proteins. What is not filtered are the proteins. So the composition of this filtrate is essentially the same as that of plasma, that is the fluid part of the blood, except that it does not have any proteins. So except for proteins, which are big molecules, everything else is there. But these are the major products that we will consider: water, glucose, and amino acids, which are filtered. Now, this now gives you a picture of how much is the filtrate formed and how much is the urine. The filtrate formed is about 180 liters per day, as we saw, or about 120 milliliters per minute. The urine formed is about only about 1.5 liters per day, or about 1 milliliter per minute. So 1 milliliter out of 120 comes to less than 1%. 1 milliliter out of 100 would be exactly 1%, but this 1 milliliter is out of 120. And so it is less than 1% of the filtrate. So more than 99% of the fluid that is filtered is taken back into the body. And that is what we call reabsorption, that it is absorbed back. Now let's see how this takes place and in steps. So this is the place where the bunch of capillaries is, and across this takes place this filtration. And the first place it passes through is the proximal convoluted tubule. And here there's reabsorption of water. Water is taken back into the blood. Glucose is taken back into the blood. Amino acids are taken back into the blood. And sodium is taken back into the blood. So far as water is concerned, about 2/3 of the water is reabsorbed, about 67%, which means 33% still stays. Eventually more than 99% will be reabsorbed, but out of that, only about 67% gets reabsorbed here. All the glucose gets reabsorbed here. All the amino acids get reabsorbed here, and a considerable amount of sodium also gets reabsorbed here. So the fluid that leaves this place in terms of volume, it is still about 1/3, about 33% of what was filtered. And to accomplish this task, this structure has to have cells which can absorb all that. And that's why you find their surface area has been multiplied, as in the intestine, through these microvilli, which look like a brush border on the surface. And these cells have to be uh, active, so they have to be able to generate a lot of energy. And therefore, they have these mitochondria, the powerhouses of the cell. So this is the type of cells that line the proximal convoluted tubule, or the PCT, where uh, 2/3 of the water that was filtered gets absorbed, all the glucose gets absorbed, all the amino acids, and a considerable amount of sodium, so that what leaves is now only about 1/3 of what entered. But still, that is quite a lot. Let's now digress a bit. Now, all the glucose that is filtered is reabsorbed, but only up to a point. There's a upper limit to how much the proximal convoluted tubule can absorb, and that is what we call the glucose threshold. Now, the glucose threshold is 180 milligrams per 100 ml. So, now the composition of the filtrate is similar to that of plasma. So, if the plasma or the blood glucose is more than 180, the filtrate will also have more than 180 milligrams per 100 milliliters. And if it crosses that, then all of it will not be reabsorbed. So, if it becomes 280, then 100 will be left behind in the filtrate, 180 will be taken back. So, roughly. So, this is the threshold for reabsorption. This is the maximum capacity of the tubule to reabsorb. And this you can see is below the level that a healthy person reaches. In healthy person, fasting blood glucose is generally less than 100, and after having a meal, it is around 150, generally less than 180. So, therefore, in a healthy person, this threshold is not crossed, and therefore one does not find any glucose in the urine. Now, the next question is then why is urine sugar not reliable enough for diagnosis of diabetes? You can understand that easily because suppose a person who has diabetes, not very severe diabetes, but has diabetes, his blood glucose, say fasting blood glucose is about 150 or 170, that would be uh, higher than normal. That is a high fasting blood glucose level. The person has not eaten anything throughout the night, and he takes an early morning urine sample, which is what is generally done. And that sample is good for many other tests, the early morning urine. But then in this, the glucose that is uh, presented to the kidneys is the fasting blood glucose. So if this fasting blood glucose in this person is say 170 or 180, just near the threshold, this person may not have any sugar in the urine. Sugar is used more or less synonymously uh, in these things because sugar is much easier to relate to for the general public. And so, the sugar or glucose in the urine will not be there in this person who gets this test done after fasting overnight and then takes an early morning urine sample. His blood glucose, fasting blood glucose, may be about 170, and therefore all of it could be reabsorbed. There's no glucose in the urine. But then, if the same person gets the test done uh, a few hours after a meal. Now, during the meal, his blood glucose might have crossed 250 or 300. Now, since it is above the renal threshold of 180, all of it will not be reabsorbed. And now the urine will show the presence of sugar. So, therefore, a positive test does give us the diagnosis of diabetes, but a negative urine sugar does not necessarily mean that the person does not have diabetes. So, urine sugar is not a reliable enough test for the diagnosis of diabetes because glucose will appear in the urine only when blood glucose is more than 180 milligrams per 100 ml, and the fasting blood glucose of a diabetic may be less than 180 milligrams per 100 ml. So, what is the solution? Therefore, we should also do a blood glucose test. If you do a blood glucose, even at the fasting level, then it will be higher than normal. It may be 160, 170 fasting, and the one would know that this person has diabetes. So blood glucose is therefore a more reliable test. A negative urinary glucose test, if there's no glucose in the urine, that does not mean that the person does not have diabetes, could still have diabetes. Now, reabsorption continues in the segments of the nephron beyond the proximal convoluted tubule. So first it enters the descending limb of that loop. We had seen that uh, from the glomerulus after the proximal convoluted tubule is a U-shaped loop. Now this is the descending limb of the loop. Now this descending limb has the property of reabsorbing water. Okay. This reabsorbs water and it has thin cells uh, without much expenditure of energy. That's why there are no mitochondria here. Water can just flow out. This membrane here is highly permeable to water, which means it allows the exit of water quite easily. However, it does not allow sodium to go out. So you can understand that because sodium doesn't go out, this keeps getting more and more concentrated. You know, if the unit of concentration here is milliosmol, starts with 300, ends with 1200. That's because water is getting lost, and therefore the fluid is getting more and more concentrated with respect to the salt. And the opposite takes place in the ascending limb. This is this can reabsorb sodium, but it does not allow water to go out. So this allows water to go out, get reabsorbed, but not sodium. This allows sodium to go out, but not water. And the result is that sodium keeps going out, and therefore this keeps getting dilute as it goes up. And so starting with 1200, now you're down to 100. Highly dilute, hmm, very watery type of fluid comes out. But this watery fluid doesn't mean that the volume is more. Volume has been further reduced considerably. Now it may be only about 90% of has been reabsorbed, only about 10% is left by the time it comes out of here. And this reabsorption has taken place in two installments: water reabsorbed while it is going down the descending limb, and sodium reabsorbed while it is going up the ascending limb. And reabsorption of sodium is an active process, and therefore it has these thick cells, fat cells with a lot of mitochondria. So, because these cells will need energy, energy will be required for reabsorbing sodium. So, if we sort of break it down to the essentials, the formation of urine is the result of filtration here, and then reabsorption, which takes place in installments. And then another thing which we have not talked about is that some of the things which are still in the blood can be sent into this fluid in the tubule through the process of secretion. So while a lot is getting reabsorbed, some substances can also be secreted here. Substances like urea, some additional urea can go, potassium. So some of the substances which still need to be eliminated from the body can be added even later. So they may not have got filtered, but some additional amount can be added here. So, this is a process somewhat similar to the way you clear a congested table. If you have a congested table like this, what is the first thing you do? You remove everything from the table. That is what the filtrate does. Then, whatever you think you really need on the table, you start putting it back on the table, and putting it back on the table. Most of the things come back, although in a more orderly fashion, but they come back. And the rest is rejected. Then, out of whatever has been rejected, you have a look again, and your mind might change, and you might feel like adding certain things further to the table. So, initially, you removed everything that corresponds to the filtration. Then, you returned what was required, that is reabsorption. And out of what was rejected, you may change your mind and pick up something and bring it back, that is secretion. By the way, this is how my study table looks like these days. It's a picture of my study table. This is what I call the studio mode. Everything else may be littered. Just make sure that the background looks clean. So filtration, reabsorption of what we need, glucose, amino acids, and plenty of water. And secretion, addition of a few substances. Another opportunity is available. You can still get into this fluid what you think you do not need. So opportunity for readjustment. Yeah. Now, around 10% of the fluid is still there by the time it reaches here. This is the end of the ascending limb. Now, what happens in the distal convoluted tubule and the collecting ducts is regulation. That is fine tuning. Depending upon the needs of the body, water, sodium, potassium, they may be reabsorbed so that finally what enters the end of the collecting duct and finally goes out as urine may be much less than what entered. So that's what happens. Around 90% has gone by the time it reaches here, but another 10% is still there, and what goes out is generally less than 1%. So that reabsorption takes place here, but that is not indiscriminate, that is not obligatory, that is the quantity of how much will be lost is regulated. So we may say that basically we have four processes going on here: filtration at the glomerulus, and then try to conserve what the body needs in this region. Uh, so about two-thirds is of the water, and all the glucose, all the amino acids are taken back, so it conserves. And then further concentration of this fluid here in two installments, take back water here and take back sodium here in the distal tubule. And then regulation of what is actually finally eliminated. Now, how does this regulation take place? And like everything else in the body, it's regulated primarily through the nerves and the hormones. We'll talk about two major hormones which regulate how much fluid and salt will go out. One of them is the antidiuretic hormone. Diuresis means passing too much urine. There are drugs which increase the amount of urine that we form. So the drugs are called diuretics. There are also commonly consumed substances which increase the formation of urine, like say tea and coffee, particularly tea, alcohol. They increase the amount of urine formed. So they have a diuretic effect. So diuresis is forming too much urine. Antidiuretic means not uh, diuretic, which means less of urine will be formed. And that happens because antidiuretic hormone increases the amount of water that is reabsorbed. And how does the body know how much antidiuretic hormone to form? For that, there are receptors in a tiny area of the brain, the hypothalamus, which we'll talk a lot about when we go to the nervous system. Now, this structure can sense the degree of saltiness of the body fluids, and based on that, it can decide how much of the antidiuretic hormone will be formed. And that's how the water reabsorption is regulated in the distal convoluted tubule and the collecting ducts. The distal convoluted tubule and the collecting ducts functionally behave as one unit. That is where the fine tuning of the filtrate takes place. That is where the fine tuning of the composition of the urine takes place. Another hormone which helps in this regulation is aldosterone, which is formed in the adrenal glands just next to the kidneys, which we saw in the beginning. And how does the adrenal know how much of aldosterone to make? For that, there is a structure close to the kidney which forms another substance called renin. And this renin, in turn, acts on a plasma protein angiotensin, which in turn, plasma protein angiotensinogen, that is, gives angiotensin. That in turn forms angiotensin, and that in turn stimulates the formation of aldosterone. Now, what is it that aldosterone does? It increases the degree of sodium reabsorption and increases also potassium secretion, which means that it can help in regulation of sodium and electrolyte excretion. That is, how much of sodium will be lost, how much of potassium will be lost. That is adjusted by aldosterone. And invariably, with sodium reabsorption, water is also reabsorbed. The two go together. So it means that aldosterone would increase not only sodium reabsorption, but also water reabsorption. And that's how it can lead to uh, retention also of water. So that is what the aldosterone does. Aldosterone does one more thing, and that is it also constricts the blood vessels, which in turn raises the blood pressure. And that actually happens indirectly through the same mechanism, because it is the angiotensin which actually increases the pressure. To some extent, aldosterone may do it because of the water retention. So, constriction of blood vessels, water retention. So, that can increase the blood pressure, which can come in handy in some situations for regulation, and it can also become the basis of high blood pressure in some individuals. High blood pressure has a two-way relationship with the kidneys. On one hand, high blood pressure can lead to kidney disease, through this mechanism. On the other hand, kidney disease can lead to hypertension. Now, questions to think some about again. Uh, some important things in what we have talked so far. Why is there no glucose in the urine? You know, when you get a urine test done, a routine urine examination done, it has no glucose and it has no protein. Now, both these substances, glucose and protein, are absent from the urine for two different reasons. The mechanisms are different. In case of glucose, there is no glucose in the urine because all the glucose is reabsorbed back. So all the glucose that was filtered is reabsorbed, taken back into the blood. And why is there no protein in the urine? That is for a different reason. That is because protein molecules are too big to get filtered. Protein does not get filtered at all. And that is why, right from the beginning, in a healthy kidney, there is no protein. And therefore, if we find protein in the urine, it indicates damage to the kidneys. Means the kidneys are damaged, kidneys are diseased, and therefore they are letting even big molecules like protein molecules get filtered, and that's how it appears in the urine. Now let's go to common diseases of the urinary tract. One of the commonest is urinary tract infection, and more common in women, as we saw. And why? Uh, the symptoms may be passing urine very frequently, burning sensation while passing urine, fever, and so on. So these are some of the symptoms which alert a person to the presence of urinary tract infection. And uh, fortunately, there are good antibiotics available which can take care of most urinary tract infections now. Otherwise, it could be a serious issue because repeated urinary tract infection would eventually start damaging the kidneys, and that can lead to then eventually renal failure. But properly speaking, these days that should not happen because urinary tract infection can be dealt with pretty successfully by using the appropriate antibiotics. And of course, prevention is better than cure. And for prevention, one of the things we talked about that women, while washing that area, go from the front to the back, not the other way around. Secondly, plenty of water because germs do not grow uh, unless the urine is pretty concentrated. In a very dilute urine, watery urine, the germs do not grow easily. And therefore, one should take a little extra water rather than less. No one about the water intake, one can be guided by two things. One is thirst, and the other is the color of the urine. The thirst will enable us to take the minimum necessary amount of water. And therefore, one does not necessarily have to wait to be thirsty to take water. One can take a little more than that. And then the urine will remain whitish in color, faint yellow. It will not become deep yellow. So if we keep the urine from becoming deep yellow, and this becomes particularly important in summers, particularly for those who have to be out in the sun uh, during the day in summers, in tropical heat. So for them, it becomes important to keep in mind to be conscious of taking enough water. To some extent, it applies also in winters because in winters we feel uh, not much thirsty. We don't feel much thirsty in the winters. And therefore, one again has to be conscious that even if we are not very thirsty, take at least enough water to keep the urine uh, faint yellow. It should not turn deep yellow. Another important sort of common disease of the kidneys is urinary calculi or stones. Stones can form anywhere in the urinary tract, in the ureters, in the bladder, or in up in the calyces and the pelvis. They can form in any part of the urinary tract. And generally, a stone starts as a small little nidus, that is a small little collection of something solid, and then around it starts growing more and more because uh, as you can see, visualize, I mean, in terms of the behavior of material substances that we even otherwise see, that if you have a little bit of something like that stuck somewhere, then a similar thing tends to stick there and collect there. So that's what happens here. Starting with a small collection, it can keep growing. And that again is more likely in a concentrated urine. A dilute urine, a stone will not start forming. It starts forming in a concentrated urine. So once again, the prevention is through taking plenty of water, more water than is strictly necessary for satisfying the thirst. Now, how about the uh, symptoms? For quite some time, there may be no symptom at all. Uh, but once in a while, what happens is that the stone that was formed somewhere up may start coming down the ureter, or it wasn't there in the ureter but silent and starts slipping down towards the bladder. So most of the time, the symptoms are produced by the stone moving in the urinary tract, particularly in the ureter. And that's when the person gets very severe pain, which we call renal colic. So that is when the person gets very severe pain. And the pain can be treated. And then, of course, it disappears and the person may forget about it completely. That also happens because the stone doesn't move and then the person may forget about it. But at the same time, it can be risky because if the stone continues to be there and blocks the flow of urine, then this back pressure builds up, and that back pressure starts dilating the part of the urinary tract, those pelvis and the calyces, and eventually it starts pressing on the area which has the nephrons and starts damaging them. That is what we call hydronephrosis. That is collection of water in the kidneys. And how does that water collect and press on the structures in the kidney, damaging them? That is because of back pressure, because of the obstruction created by these stones. And therefore, stones can have serious consequences. It's not just the occasional pain, it can have serious consequences. How about the treatment? Depends upon the position and the size of the stone. As a rule of the thumb, stones which are less than 5 millimeters in diameter. Generally, we can uh, have a rough estimate of the size of the stone from an ultrasound. And if the stone is less than 5 millimeters in diameter, generally it passes on its own. So just plenty of water is enough, and it starts getting smaller and eventually passes out. Of course, while passing out, it may again cause pain, but then that pain is a desirable pain because it is helping the stone go out. Uh, if the stone is big, unlikely to pass out on its own, then what one should do is to uh, treat it in some other way. There are different types of surgical techniques available, some which require opening up the abdomen, some in which that is not necessary. Uh, Something, a small thin tubular structure which has a basket at the tip can be passed through the urinary tract and the basket catches hold of the stone and it can be brought out. Those are some of the surgical techniques which can be used for dealing with stones, depends upon the size and the location of the stone. One might say that suppose one does not want to undergo any such surgical technique, then what should one do? Is there any other mode of treatment? Yes, and there are some other helpful treatments available in Ayurveda. But then one has to give them a try for a limited period of time because of the serious consequences of these stones. Doesn't mean that the stone has to disappear miraculously as a result of that. But what one can do is that, say, every 3 months or 6 months, repeat an ultrasound so that one finds that on the whole, is the stone staying the same size? Is it growing or is it getting smaller? If it is getting smaller, then one can continue that treatment, of course, along with plenty of water and hope that the stone will pass out on its own. On the other hand, if it stays the same, and particularly if it starts growing in spite of that treatment, then it's better to go in for a surgical treatment. So it's not an either or approach again. We have all these approaches available irrespective of the system of medicine. What is important is that the person should understand the disease and make appropriate choices. Acute renal failure is not a common problem, and not general public doesn't need to know too much about it either. But all the same, it can happen as a result of loss of fluid from the body to such an extent that the kidneys do not get enough blood flow. So, if the glomeruli are not getting enough of blood, not only the urine will not be formed because of this lack of blood, the kidney's own nutrition, because the kidney also needs to live and gets its nourishment from the blood that is flowing through it. So, if not enough blood is flowing, not only the filtrate cannot be formed in the glomeruli, the kidney starts getting damaged And that is what we call acute renal failure. And one of the situations in which it can happen is severe dehydration, say in diarrhea, or a large volume of blood lost in an accident. Now, these are some of the things in which there can be a sudden failure of the kidneys. Acute renal failure, if taken note of in time, is generally reversible, because then the kidney returns to normal function when the blood starts flowing through the kidneys. But during the interim period, after it has failed and before blood starts flowing into the kidney, a few rounds of dialysis may be needed. Now, what is dialysis? In dialysis, what is the principle is simple. The technique is complex, but the principle is very simple. What is done is that the blood is brought in contact through a membrane which allows the passage of substances across it, water and electrolytes and urea and things like that. So there's thin membrane in the machine which allows the blood to come in contact with a fluid which has a composition very similar to the plasma, but does not have those substances which we want to eliminate. So we want to eliminate urea. So the fluid that is passing through the machine does not have urea, but otherwise its composition is very similar to that of plasma. So the result is that when the materials, water and electrolytes are exchanged from this fluid passing through the machine and plasma, and from the plasma to the machine fluid, not much changes because the composition is very similar. But the fluid that is passing through the machine does not have urea, and therefore, as materials move from a higher concentration to a lower concentration, urea will move only from the blood to the fluid passing through the machine, and that's how the concentration of urea will keep going down, and it will not build up to very high levels because the blood in the body and the fluid in the machine, they are both moving, and therefore this difference will remain, and this urea will keep getting transferred from the blood to the fluid that is passing through the machine, and the two are separated by a thin membrane which allows this type of transfer both ways. So that is, a few rounds of dialysis may be needed when the person is in acute renal failure. In the meantime, the basic cause why the kidney failed, that is inadequate fluid volume or blood volume, that will be taken care of. When that happens, then the blood starts flowing to the kidneys again, and the kidney will pick up the function once more. So acute renal failure, therefore, is essentially treatable and curable. However, the story of chronic renal failure is different. And some of the major causes are repeated urinary tract infection that can eventually damage the kidney so much that there's chronic renal failure. Stones, which may have obstructed the kidney and destroyed renal structure because of the back pressure building up from the uh, ureters upwards and widening up the spaces, fluid containing spaces in the kidneys. And the result is pressure on the structures, the areas which have the nephrons, and for the nephrons under this pressure, uh, failing, they're getting destroyed. So it can be a complication of the stones or infection, or it can be the result of uh, high blood pressure, and it can also be one of the complications of poorly controlled diabetes. Nephropathy is one of the major complications of diabetes. So these are all various reasons for which there may be chronic renal failure. Now, chronic renal failure, unlike acute renal failure, is not reversible. However, it's a slow growing process, and one may be able to delay the progression. And if one is able to delay the progression, again, a lot can be achieved because of the reserve that we have in the kidneys. So the kidneys may not be in top shape, but the person may continue to have reasonably good life so long as the progress of this failure is not very rapid. And this can be accomplished again through plenty of water and an appropriate diet in which we are not overloading the kidney with urea. And that will be possible if we take just the enough quantity of high quality protein. So not too much protein, at same time high quality, which means it gets utilized for manufacturing body tissues and does not get burnt down to urea. It does not get used up as fuel. So just enough protein so that does not get used up as fuel, and the type that will not get used up as fuel but will instead will contribute to the building up of the structures of the body. So diet plus plenty of water, so long as the failure is not at a level where plenty of water itself is not allowed, that can also happen. But anyway, so the main thing is that the progression of chronic renal failure can be slowed down. But if it progresses and reaches a point where there is impairment of renal function, there is derangement of the saltiness of the fluids, it is electrolyte imbalance, the acid base imbalance. When these things start happening, accumulation of the waste products like urea, when those things start happening, then there are a number of treatment options. One of them is repeated dialysis. Dialysis is time consuming. It may be required twice a week. The dialysis uh, is an expensive technique, but at the same time, it can keep a person with chronic renal failure alive for years. Now, this presents an ethical problem because no country in the world can afford dialysis for as long as it can keep the person alive for every person who has chronic renal failure, and as long as dialysis can keep this person alive. So, that is an ethical issue. Uh, what is, however, possible is to have transplant the kidney. Now, two types of transplants are possible. One is transplanting a cadaveric kidney, that is, a kidney taken from a dead body. Now, this is one of those transplants which is relatively successful. From many other parts of the body, the tissues are not accepted easily. But in case of the kidneys, the acceptance is fairly good, and therefore the kidneys taken from a dead body can be used. And till that kidney becomes available and the surgery is carried out, one can do a dialysis. So dialysis can be done periodically till a transplant can be done. So one of the transplants can be from a dead body, the other can be from a living person who has donated a kidney. So these are the options that we have in chronic renal failure. And chronic renal failure is generally a complication of urinary tract infections, calculi, high blood pressure, or diabetes. Now, uh, two of the tests which are most commonly done on the blood as the tests of kidney function, renal function tests as they are called, are blood urea and blood creatinine. Now, which of these two is more reliable? Out of the two, blood creatinine, in fact, is more reliable. Now, what is creatinine? Creatinine is the breakdown product in the muscles. While the muscles are using up the fuel and working, they produce creatinine, and this creatinine appears in the blood, and then it is filtered and removed from the kidneys. Once it has been filtered, it is neither reabsorbed nor secreted, and therefore uh, it has a relatively constant sort of a level, because if the amount of breakdown in the muscles is constant and the filtration in the kidneys is constant, 120 ml per minute. After that, if it is neither reabsorbed nor secreted, the blood creatinine remains essentially constant, and uh, it will start going up only when the kidneys cannot filter enough. So when the filtration surface is damaged, uh, not enough may be filtered, and it will start accumulating in the blood. Blood creatinine is a better indicator. Blood urea, uh, not so reliable, because urea is filtered and also reabsorbed and secreted. And further, urea uh, would also be affected by the function of the liver because made in the liver. And most important, blood urea could be affected by the diet, which means the amount of protein and the quality of the protein would affect the amount of urea formed, and therefore will affect blood urea apart from the renal function. It's a fairly good test, a fairly good indicator, but all the same, if one has to compare blood urea and blood creatinine is a better indicator, a more reliable indicator of kidney function than blood urea. Blood creatinine is more reliable because it's not affected by other factors such as diet. So to sum up, essentially the prevention of renal disease is through taking enough water. So sips of water is all it takes to keep the kidneys shipshape. Prevents the two commonest problems of the urinary tract infection and the stones and their sequelae. Suggested reading, this popular book, The Human Machine, How to Prevent Breakdowns, and these two textbooks, Fundamentals of Physiology and Understanding Medical Physiology. Sri Aurobindo Ashram Delhi branch, the place from where I'm speaking and where I stay and work, to which you are all welcome. And for questions and comments, apart from the questions we can have at the end of the session, you can always write to us on yes@yesspirituality.com. Gratitude to the Mother and Sri Aurobindo for making these sessions possible. And thank you all for being there.
There's one question in the chat box. Holding up going to washroom can cause stones. Is this true?
Of course, one should not hold up the urine. If you're feeling the urge, one should uh, try to find an opportunity and place to also void it, to get it out of the body. But I'm not sure one can do it often enough and frequently enough uh, to let it just stay there and finally those stones to form. I doubt if that can be any, at least a major sort of reason for forming stones holding the urine. But that reminds me of a few, I can say a few related things to it. Uh, one should try to avoid it before one feels that strong urge so that one does not get into a situation where one feels compelled to just run to the toilet. Secondly, in general, women can hold urine much longer than men. And this may be a social conditioning because which has then led to corresponding changes in the body over a period of thousands of years because women have less opportunities for voiding than men have uh, where they can do it. Uh, and the general principle, which is summed up in one of the common Hindi proverbs, uh, कि अगर आपको डाउट है खाऊं या ना खाऊं तो मत खाओ अगर डाउट है टॉयलेट जाऊं या ना जाऊं तो जाओ If you have doubts about whether to eat more or not, don't eat more. If you have doubts about whether or not to go to the toilet, do go.
I had a question. Is the formation of stones due to some fault in filtration in the kidney?
I don't think so because the filtrate is extremely dilute, the same composition as plasma, and the stones are because the urine gets concentrated more, which happens in the later segments of the nephron, not at the level of filtration. Because the body has less fluid, it will try to retain more. And when it tries to retain more, the urine gets concentrated, and that then encourages the formation of these crystals of salts around which more salts can accumulate. However, diet sometimes has been blamed for some of the stones because some substances like tomato, spinach, etc., contain oxalates, which can form oxalate stones. So some of the precautions are suggested for prevention, and particularly if a person has a tendency to form stones. And again, that's an important thing because for some mysterious reasons, some people have a very strong tendency to form stones, everything else remaining the same. So these are some of the mysteries which we still don't fully understand. But then these people naturally have to take the same precautions more conscientiously, drinking enough water, avoiding a few items in the diet, and so on. Anyway, thank you, Divya. You always ask some good questions.
All right, if there are no more questions, then maybe we can close today's session. And thank you, everyone.